My dear students, in this video, I am going to discuss some points on difficult to treat ICU infections. I will cover the gram-negative infections in this lecture, and that's why the title goes as Difficult to Treat ICU Infections 1. Subsequently, in other videos, I will also elaborate on gram-positive organisms and fungal infections. So let's start with the case. The first case is a day 14 polytrauma patient on ventilator who is having new fever with rising vasopressor requirements, increased purulent secretions from the endotracheal tube. The chest X-ray shows signs of new infiltrates. The PF ratio is 130, and the bulk culture, which was sent 2 days prior, grows Acinetobacter baumannii. This is the antibiogram which is available, resistant to peptides, cefepime, meropenem, MIC is greater than 16, imipenem, levofloxacin, amikacin, colistin is susceptible, MIC is 1, tigecycline is intermediate, as well as it is sensitive to minocycline, high dose, sulbactam, and cefiderocol. Although cefiderocol is not available at large in our country, in the pharmacies, although bearing a few places where it is available in the gray market. But the question is, how would you treat this patient? Going by all the evidences, the evidence that is most pertinent to discuss here is this study, which is the ATTACK trial, the efficacy and safety of sulbactam, durlobactam versus colistin for the treatment of patients with serious infections caused by Acinetobacter baumannii calcoacetic complex, which is a multicenter randomized phase 3 non-inferiority trial in 181 patients, where the sulbactam erdobactam group had a mortality of 19% versus 32% in colistin group and met the non-inferiority criteria. So true CRAB VAP with septic shock combination is often preferred. Drugs with real activity include sulbactam, colistin, and minocycline. One should avoid tigecycline as a monotherapy because of the lung site where its concentration is suboptimal. And therefore, the suggested ICU regime would be high dose sulbactam based regime, including ampicillin sulbactam, but targeting sulbactam to the tune of 9 to 12 grams per day, along with prolonged infusion plus IV colistin with loading, along with nebulized colistin for VAP. Although the nebulized colistin for VAP is less often used nowadays, but there are evidences to support its use in such cases. If cefiderocol becomes available, when cefiderocol becomes available, or if it is available, then cefiderocol monotherapy or in combination with colistin or high dose sulbactam can be preferred. So the important pearls in this carbapenem resistant Acinetobacter baumannii pneumonia is that sulbactam exposure is critical, so underdosing is common. So we will have to rely on high dosing, and we'll have to consider inhaled colistin as an adjunct, not as a monotherapy, and always reassess the ventilator circuit and secretion management and de-escalate if possible after as soon as patient starts responding and clinical improvement takes place. Going to the second case, this is ICU day 6 of a post-op perforation peritonitis patient with anastomotic leak. Now septic shock has in supervened and patient is on high dose norepinephrine. The two sets of blood cultures which were sent were positive for Klebsiella pneumoniae, and the genotype report shows NDM carbapenemas with ESBL positive. So this is the antibiogram which is showing resistant to all save colistin, tigecycline, and phosphomycin. So how do you treat? One study among all, which was a retrospective cohort study from South India, the Capri study, in 106 patients showed that the mortality was with ceftazidime avibactam plus aztreonam was 29.2% as against 56.9, that is almost 57, in the polymyxin group in high NDM prevalence setting. Now, more often when we look into studies from abroad, they are not in high NDM prevalence setting. Whereas in India, because of higher prevalence of NDM, these are the studies in high NDM prevalence setting. So when we see such differences, then there is, of course, rational to prefer ceftazidime avibactam plus aztreonam over polymyxin in the patients. So NDM hydrolyzes almost all beta lactams, but not aztreonam. However, aztreonam is hydrolyzed by ESBLs, so this requires protection with avibactam. So now, once we have aztreonam avibactam combination available, then that will probably become the first choice. But as of now, synergistic combination of ceftazidime avibactam plus aztreonam has to be used for applying the pharmacological trick. And till the time we don't have, we can give this concurrently, it's as an extended infusion, which we normally do, with or without IV phosphomycin or colistin in the first 48 to 72 hours if the patient is in refractory shock. So the important pearls here is that when we look for genotype guided therapy, for KPCs and OXA48, we go for ceftazidime avibactam combination. For NDM, VIM, and IMP, we go for ceftazidime avibactam plus aztreonam. And because nowadays we know that the penicillin binding protein that escapes the action of avibactam sometimes, so therefore aztreonam it covers. So aztreonam and avibactam becomes important. The report says that SAS-AV resistant in NDM doesn't rule out its use in combination with aztreonam. So when we are using aztreonam, it is always good to use it. Ignore that whether this SAS-AV is resistant or not. Moving on to the third case, a 50-year-old man on ECMO for severe ARDS on day 10 has increasing secretions with rising FiO2 requirement and also the procalcitonin values going significantly up. The bulk culture grows Pseudomonas aeruginosa and high oculum, and the antibiogram shows resistance to most of the antibiotics except amikacin, colistin, and ceftazidime avibactam. So how do we treat? Again, if we go into most of the trials, then we pick up the best possible explanation. So this one is a combination with ceftolazone tazobactam, although tazobactam is not available currently in India, but we have ceftazidime avibactam. So this is the ASPECT NP trial, which was a phase 3 non-inferiority trial in post-hoc subgroup patients who had failing prior therapy. And in that group, the 28-day mortality to ceftolazone tazobactam was 22%, 22.6% as opposed to 45% in the meropenem group. So it responded much better to the meropenem. Reasoning is that the difficult to treat Pseudomonas, they're non-susceptible to all standard beta-lactams and fluoroquinol. So newer anti-pseudomonal beta-lactams are active like ceftazidime avibactam, and in play abroad, ceftolazone tazobactam has better therapeutic success. In patients with ECMO where there is increased volume distribution and possible sequestration in the circuits, one has to go for loading dose followed by prolonged infusion. So it is suggested that ceftazidime avibactam has high dose extended infusion along with amikacin for a short period of 48 to 72 hours if the patient is in shock would be helpful in such scenarios. So the important pearls are that in ECMO and in CRRT, one should always use loading dose and then prolonged or continuous infusions. Avoid colistin monotherapy when a safer, potent beta-lactam is active, and one has to reassess for VAB bundle compliance and go for de-escalation once patient is stabilized. Moving on to the fourth case, a 69-year-old male with chronic Foley's catheter following spinal injury and subsequent surgery, is admitted with septic shock and AKI. Urine and blood cultures both grow Enterobacter cloaca complex. The antibiogram shows resistance to a lot, many, but sensitive to cefepime, ertapenem, meropenem, ciprofloxacin, and amikacin. So how do you treat this patient? Again, if you go by the study, we all know about the Merino trial, which compared piperacillin tazobactam against meropenem in ESBL producing organisms. But this is the Merino 2 trial. This will also come out in 2002, which found no statistically significant difference in clinical or microbiological efficacy between meropenem and piptaz in selected patients. However, risk of treatment failure remains high in ICU in patients with VAP and AMC-D-repressed strains. So the reasoning is that Enterobacter cloaca has inducible AMC beta-lactamase, which can turn resistant during therapy to cephalosporins and piptazo. So in septic shock with bacteremia, the safest is to start carbapenem initially, and after stabilization, if source is controlled and MIC is favorable, it can be a way one can step down to the lower regime. So initially, it is suggested that one should start on patient should be started on extended infusion of meropenem, and once stabilized and clearance is improving, consider step down to cefepime if it is having low MIC and clinically improving, or oral ciprofloxacin if susceptibility is good and there is good gut absorption. So the important part is that one should avoid piptaz for serious invasive infections due to AMP-C producers like this Enterobacter cloaca complex, and always think inducible resistance with Enterobacter, Citrobacter fruendi, Serratia, etc. Moving on to the next case, it is a hematological malignancy patient, post-chemotherapy neutropenia, intubated for respiratory failure. The bowel grows Stenotrophonas maltophilia as predominant organism with compatible clinical features. That is, patient is clinically also sick, and hence it is not just a contaminant. So the antibiogram shows resistance to piptaz and mero, but susceptibility to ceftazidime, levofloxacin, trimethoprim sulfoxazole, and tigecycline, which shows variable. So how do you treat this patient? Now, this is a systematic review on Stenotrophonas maltophilia, which has more or less taken a good number of studies, because with Stenotrophonas maltophilia, we don't find large RCTs as such. In fact, no RCTs exist to date, only observational studies are there. So trimethoprim sulfamethoxazole remains the first line. In severe ICU infections, adjunctive or alternative agents may be added, but evidence is weak. So combination therapy may be considered in high-risk patients. So they are intrinsically resistant to many gram-negative regimens, including carbapenems, and trimethoprim sulfamethoxazole is the usual drug of choice. Levofloxacin or minocycline can be alternatives. So it is suggested that high-dose TMP SMX, that is what we are available in India, is 240 mg 6 hourly, especially if it is severe. But we should consider an addition of levofloxacin if patient is very unstable hemodynamically or if the MIC is borderline. So the important pearls is that escalating carbapenem for gram-negative coverage can actually worsen selection of Stenotrophonas maltophilia. It is always good to recheck that whether it is true pathogen or just a colonizer. But in neutropenic patients, high burden bowel with compatible picture should not delay treatment. Moving on to the last case, a 35-year-old man with underlying bronchiectasis as admitted with severe pneumonia and is now on ventilator. The bowel culture grows Burkholderia cephacea complex, and the antibiogram shows resistance to the majority, but sensitivity to ceftazidime, levofloxacin, minocycline, and trimethoprim sulfamethoxazole. So how do you treat it? Now, this is a case where we get colistin is intrinsically resistant to colistin. And this study has shown that for Burkholderia cephacea complexes, therapy is guided by susceptibility with minocycline, trimethoprim, ceftriaxone, and ceftazidime. These are the prominent antimicrobials, which are usual, but very important thing is to understand that source control is critical, and decision making largely is empirical or expert opinion based rather than trial based. We don't get trials with this condition. So this is a notorious, particularly because of it is of its studies which has been done in cystic fibrosis and bronchiectasis, and in ICU it is often MDR. So colistin being intrinsically resistant is out of the list. So other active options include ceftazidime, Ceftriaxone, minocycline, sometimes meropenem, levofloxacin, but it is always suggested to start with high dose and extended infusion of ceftazidime and add either trimethoprim sulfamethoxazole, especially if the patient is having severe pneumonia or bacteria. So the important part is that don't use colistin because it is intrinsically resistant. So don't even look into the report and consider long-term treatment duration and have a careful follow-up, particularly in patients with structural lung disease, as it tends to recur too often. There are a lot of caveats and limitations because all the studies which look upon them, they're largely retrospective or observational, not always RCTs, particularly for VAP. And the VAP subgroup in the meta-analysis which I cited did not show statistically significant mortality benefit of cefiderocol versus colistin. Then the PKPD in ventilated patients and biofilms, secretions, etc. on endotracheal tubes, tracheostomy tubes are different from bloodstream infections. So those differences also influence the vulnerability or resistance mechanisms. Then the local susceptibility patterns matter. If sulbactam's MIC is high or isolate resistant, then these regimes may fail. So my take home message for each one of these conditions is that if it is a CRAB VAP, use sulbactam based therapy as backbone and optimize PKPD. Consider combination in patients with shock. In NDM or CRE, or that is Klebsiella septic shock, genotype determines the therapy. NDM needs Cas-AV plus aztreonam, not colistin monotherapy. In difficult to treat Pseudomonas aeruginosa VAP, we prefer newer anti-pseudomonal beta-lactams. In places where ceftolozane tazobactam is available abroad, they use it. Since we don't have it, we use ceftazidime avibactam with PK optimized dosing over colistin based therapy. For ESBL, AMC, Enterobacter cloaca complex sepsis, carbapenems remain the most reliable option till date. Even in severe illness, one should avoid peptides for high oculum infections. In sternotophonous maltophilia pneumonia, we should not escalate carbapenems, they make it worse. Choose trimethoprim sulfamethoxazole in the first instance and add levofloxacin or minocycline if patient is critically ill. For Burkholderia cephacea complex ICU pneumonia, use susceptibility-based therapy. Usually trimethoprim sulfamethoxazole works, followed by ceftazidime and minocycline, but one has to ensure strong source control. Thank you very much.